Well, if there's one thing I often tell my patients, we cure a majority of breast cancers. The journey gets tough, but the tough can get going, and most women do come out victors.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. In this episode, we hear from Dr. Priya Vishnubhotla, a medical oncologist here at Piedmont, who shares how far the field of breast cancer care has come, from personalized treatment and groundbreaking therapies to survivorship and lifestyle-driven prevention. She highlights the importance of access and equity in care, the role of exercise and community support, and why she reminds her patients that breast cancer is not only treatable, but in many cases curable. I can remember that when I first started my clinical career, a breast cancer diagnosis was really devastating. And it's not to say that that's gotten easier, but I think originally this would seem to be always associated with, hair loss, major surgery, chemotherapy, those types of things. And I know that there's been a tremendous amount of research, increased access to screening, treatment options have changed and developed. And, I don't know if that original perception from the beginning of my career is stuck with people, and that's maybe one of the reasons why, people are concerned about access. But maybe you could talk about how the whole field has changed, or even from the research and the screening piece in over your career, and maybe a new diagnosis shouldn't be a devastating diagnosis, although difficult.
I think that's well said. I'm going to build on the latter aspect of what you said, and I think it's all thanks to first the advancements in adjuvant treatment. What does that mean? So every new breast cancer patient today is not just should it be treated as a unique diagnosis, but I think we persevere and move towards personalized care for each breast cancer patient. What does that look like from my eyes, my vision as an oncologist? Every woman has access to a number of tools, if you may, that allow us to risk stratify every tumor with regard to the risk of recurrence, and hence either de-escalate or escalate the care. For example, in the last 1 to 2 decades, we have really become smarter in understanding that breast cancer has different molecular subtypes. And hence, every woman with early breast cancer is able to get some of these, what we call gene expression profiling, done on their tumors. We don't do it for all the tumors, but we certainly do it for a big chunk of the tumors. This allows us to therefore, tell a patient whether they need additional treatments for curative intent or not. We have better understanding of biomarkers, although there's a lot more work to be done. We better understand the tumor biology, although again, there's a lot more work to be done. An example I have for you is the world of the HER2 protein. About 20 to 30% of all breast cancers are driven by overexpression of HER2. However, with newer drugs called the antibody drug conjugates, we are able to use them even in patients with lower levels of HER2 expression because drug delivery has improved. So the field has changed from better understanding of tumor biology, better understanding of the tools that can predict for risk of recurrence, better understanding and therapeutic drugs that will lead to improved outcomes, most of the time survival, women living longer and getting cured from the disease. So we have come a long way with newer drugs, newer techniques, and de-escalating what used to be a major radical surgery has now often we are able to eliminate even the role of axillary dissection or how much
Is
surgery
that right?
patient needs, yes.
Interesting.
And can we select better for even sentinel lymph node biopsy? Can we eliminate sentinel lymph node biopsy in certain groups of patients? These are the trials. An example I'd like to share is early data in non-invasive disease that was presented recently at one of the San Antonio uh, breast cancer meetings, showed that we are able to potentially just do active surveillance on patients, certain groups of patients. Again, I'd caution against using blanket statements, but
Hmm.
these patients, some of them could potentially not need surgery because at 2 years, the outcome was similar in low risk, non invasive patients as having what we call guideline concordant care, meaning having surgery, radiation, hormonal therapy. Patients who had active surveillance had had similar outcomes. So this is what I talk about de-escalating care. We are getting better at monitoring the disease, meaning that we have circulating tumor cell assays, which we are learning. We're still in the process of learning. How do we use them better? Who should we use them? How can we monitor the disease better? So a very exciting field. Um, as a patient, you should have access to many of the drugs and or interventions I mentioned already. And clinical trials, of course, play still a very big role in high-risk patients.
That is fascinating. I'm trying to imagine this transition. The first thing that came to mind in the older days when we had maybe just visibility about what was there, but really didn't understand what the tumor was or how the treatment might have been differentiated. Yeah, I love the fact that you just described that we have the ability to tailor the approach to the individual patient, which what I'm hearing in that is not only what the tumor represents, but also even specific preferences and the needs of an individual patient can be considered in the treatment.
Indeed, indeed. I think a lot of it is that shared decision making and the patients recognizing the benefit or lack of each is some of the treatments that we do propose.
That's fascinating.
Mhm.
You mentioned non-invasive and invasive,
Mhm.
and I was wondering if you could maybe talk about what that means in lay terms and how to think about that diagnosis differently.
Yeah. I mean, for patients, it can be confusing. Non invasive disease is often denoted in our world as stage 0. So I try to tell my patients think of an analogy where you have um, a prison wall, or if you may, the duct or the lobule where these cells that have learned that ability to clone themselves, they have learned the ability to live and clone, make 1 to 2 and 2 to 4. So they're dividing. The rate of division varies for each cancer, but they are dividing. If they all are within this prison wall or within the wall of the duct and they haven't breached the duct, that's non-invasive disease, if you may. The minute the duct is breached or invaded, that changes the nature of the game because now you have cells that have this ability to clone themselves that have left the site of where they started. And hence, it's now where and how they spread is the art understanding of tumor biology that I talked about. So non-invasive disease is a precursor to cancer. It doesn't mean you have cancer. And we used to treat everyone the same, but now have learned that not all non-invasive disease needs to be treated to the same extent. And perhaps some of this can be watched, monitored, treated even with oral medications. That is the main distinction, is this invasion of the ductor, invasion of that lobule that happens, the breach that happens that leads to cells that are able to now leave the site of origin and can spread to other areas, lymph nodes, bloodstream, and hence the burden of the disease is very different.
Okay. Thanks for that explanation. It helps.
Yeah.
Are there, and these days everybody's looking at different types of risk factors for different types of diseases and illnesses and trying to manage to that. Would you say that both the non-invasive and invasive have similar risk factors? Are they totally different diseases? What do we know about risk factors for developing breast cancer, even more broadly?
I'll tackle the broad question because non-invasive and invasive disease are spectrum of sort of the same animal. Some
Sure.
are more aggressive, some not. But the risk factors, what I want folks to recognize is about 30% of breast cancer results from one of the modifiable risks, for example, excess body weight, lifestyle, inactivity. This is a huge chunk with regard to modifiable risk factors. You have the non-modifiable, or rather you have the ones that we often think about from the hereditary standpoint, from the genetic standpoint. Those we have made tremendous progress on that front as well. The most common or more common of the gene mutations that we recognize is called BRCA1 and 2, but we recognize a larger panel of genes that can contribute to that genetic risk. Having said that, when we do, as oncologists, offer this testing to a large proportion of patients, we talk about their risk reduction, but again, is individualized reduction from perspective of the stage of the disease. If someone's diagnosed with early stage with a genetic or inheritable risk, not only do we offer more surgery, reducing their risk for future disease, we also talk about other risks, ovarian cancer, and how do you reduce that risk? For example, how do you test cascade tests or test other family members so they can have access to preventative, interventions, if you may. But also, finally, talk about newer drugs. We have something called PARP inhibitors that we use in the treatment of these patients with genetic risk and have updates that show significant survival benefits when they're used in these groups of patients. So, broadly, risk factors, I think genetic, true hereditary breast cancer syndromes are, when you look at all breast cancers, it's a small number,
Okay.
less than 5%. Majority from the lifestyle perspective is something that young women can take in charge of their health and modify these factors. But lastly, age, I mean, breast cancer, if we all live to be old enough to be 80, 90, 1 in 4 or 5 women will get breast cancer. It's a factor of age.
Not dissimilar to the prostate
Yeah.
discussion.
Yeah.
Interesting.
At Piedmont, quality care changes lives. Meet Brad, a healthy former Marine who unexpectedly suffered 5 heart attacks and then heart failure. He credits Piedmont with saving his life.
The teamwork it took to provide me a path forward through a surprise heart failure and almost 5 months of intensive care in 3 different Piedmont hospitals is difficult for me to even imagine, but you guys nailed it. How do you thank someone for the gift of life?
Hear more at piedmont.org/qualitycare. Piedmont, real change lives here.
There's common themes, it seems. This weight control,
Yeah.
activity level, lifestyle is their relationship to. There was I think a big article last year publishing the relationship between alcohol and a variety of different cancers. Other type of lifestyle choices.
Oh, I want to also mention the benefit of exercise, the flip of it, right? The benefit of exercise is seen even in patients with diagnosed breast cancer, even in advanced stages that there is a definite correlation of benefit from exercise. So that's a big theme for survivors.
Interesting.
Once you've completed your treatment, it's a big theme of ensuring that patients recognize this benefit.
And just a follow-up question related to that. So for all of these things, let's say that someone has his weight's not under great control, pretty sedentary job, not very active. Like, is it really something that even just getting started and even having like a 5 or 10% improvement has an
Yes.
impact, or is there something more significant than that that's necessary to get a benefit?
We generally talk about getting started, but the degree of impact, it's obviously the less insulin resistance you have, the less insulin-like growth factors you have, you reduce your risk of recurrence. So it's sort of that continuum that plays into the aspect of overall survival, as you'd imagine. But I can't quantify that this degree will lead to this much benefit. But it just is part of that whole continuum.
Okay, thank you.
Mm-hmm.
So let's say that someone newly diagnosed with breast cancer is listening to us. What advice do you give them?
That's a good question. I would first tell them that they're not alone, that each patient's diagnosis, as I mentioned before, is unique. Therefore, take your time in understanding the disease and recognize that the newer treatments at every stage have led to significant improvement in survival. Lastly, I want to say that we're doing better in the quality of life aspect. Even if a physician does propose treatments that one can perceive as toxic, supportive care and quality of life, we do much better whether we support patients through their treatments better. I think we also are having those conversations that continue into what can we do to alleviate. An example classic is cold capping. We do use cold capping to minimize chemotherapy-related hair loss. It still happens in certain chemotherapy regimens, but at least do due diligence. If you're not comfortable, speak up. Seek opinions. You have time, and recognize that there are many supportive aspects that we can do to improve your journey through this challenging time. And last but not least, guilt. Many of the patients, what did I do? Did I do something to cause this? I think that is something we should really eliminate. We should really have the women. That's not something that's positive in this whole process. So,
Thank you for saying that.
mm-hmm.
What about friends and family? What's the best way to provide support?
I think for friends and family, recognizing that every I want to say one more thing to patients, to the point that I made, that each cancer and each patient is unique. I'd caution against comparing notes, right? So because so and so got this versus that.
So don't post everything on Facebook.
Yes, so those are the places where you can certainly get overwhelmed because you're sort of comparing the notes. But to friends and family, I'd say, listen, this is an overwhelming journey. You need to be non-judgmental and supportive through the journey to each patient. There will be many days where there'll be doubts, but you just need to keep putting one foot in front of the other and supporting. Caregiver fatigue is a real thing, but also recognizing that the patients are going through a tremendous amount as they pass through their different steps of their treatment.
Well, that's good advice. The other thing I will tell people is if you're going through something significant like this and you have the ability to bring someone with you to the appointments,
Yes.
that always seems to help, because we all hear different parts of it, and I think when we're going through it, it is definitely tough to catch everything.
Very well said, Dr. Knight. I do agree that, these are the appointments that you need to have someone else listening along with you.
So let's talk about a little bit about survivorship.
Mhm.
So how has that changed over time?
I think the first aspect is understanding what survivorship is. So we now, I think, um, recognize that every woman that starts this journey is a survivor through life,
Hmm.
and they will have challenges. So to provide support through these challenges is the goal of survivorship, whether that is sexual health, having those conversations because side effects of therapy, return to work, financial challenges, you know, recovery through the process. A survivorship clinic generally provides patients with this supportive care because there are many treatments that we use that continue after the chemo and or radiation and surgery is done. We call hormonal therapies, or the chemotherapies that we use can result in side effects and impair return to work, for example. Patients can have any number of other challenges they meet during this process. So survivorship clinic is actually a standard that most places strive for, to allow for the women to have these conversations and get the support that they need during this process.
That's great. How do either of those programs, or how do you help patients manage the fear of recurrence?
I think first is to be able to hear the concerns, because many patients may be vocalizing actually not just the treatment related side effects, but often signs and symptoms that are concerning enough that require us to intervene. So to be able to listen to them and discern what is necessary for us to intervene, and where you reassure them about the fact that uh, you are cured, and this journey from here onwards is to monitor for those signs. Mm, It is also helpful to use tools, clinical tools that can reassure them about their cure rates, about their risk of recurrences, and how you're mitigating it. Is helpful as you converse with them. It is a continuous process, and it often can ebb and flow. Some patients are feel better, and some often can have these episodes of anxiety. And I think the first thing as physicians and as clinical teams we do is listen and understand where the patient's coming from and educate them about their disease process. It is not easy, though. I recognize the challenges that come after therapy and what leads to anxiety in patients.
Well, it's nice to know that there are physicians like you that are there to provide support for these patients. The relationship starts at the diagnosis, but sounds like the relationship continues really well after that core treatment is done, to continue to monitor for symptoms, make sure that they're connected to the right supportive network, and potentially even remind them about the lifestyle behaviors that kind of help manage some of the risk going forward too.
Absolutely.
I was wondering if you had one thing that you wish everybody knew about breast cancer that you wanted to share. Just give you an opportunity to speak directly to our audience with your final thoughts.
Well, if there's one thing I often tell my patients, we cure a majority of breast cancers. We don't cure hypertension, diabetes, heart failure, but we do cure breast cancer. The journey gets tough, but the tough can get going, and most women do come out victors. We do, which is where I use the data up front to say, hey, the survival of breast cancer has improved tremendously over the last several decades. So I am an optimist. So I tend to reinforce the optimism, but it has to be the realistic aspect of really using the best available treatments and the best available data to guide our decision making. So from the standpoint of the clinical team, we should support the patients with what is the best treatment plan for them, educate them, share decision making with them, and also allow them to ask questions and reassure them that this is a curable disease and this is 2025 and we're making great strides. The last thing I'd say is clinical trial participation for all those brave women who have helped us move breast cancer to this stage. I'd urge on every patient to clearly consider if there is a trial available to look at it from the perspective of an opportunity that will potentially improve outcomes as well.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.